Yeah, we would like all of you to enjoy the sessions that we've prepared, and we hope that you will all have a good time at this conference.
And I think after this brief introduction, we would hand over the mics for the chairpersons of the next session, which is oral abstracts.
Infiltrative CD8 lymphocytosis syndrome. Do we have Dr. Sunil Kapoor? Come. Dr. Sunil Kapoor is from Pune. Sunil, can you give us the name of your institution? I didn't. Sunil, you'll have 10 minutes for your presentation, or 10 minutes, and 5 minutes to take questions?
My name is Dr. Sunil, and I'll be presenting a case study regarding recurrent acute flaccid paralysis in a child due to diffuse infiltrative CD8 lymphocytosis syndrome. Next slide, please. It's not working. Okay. So what is diffuse infiltrative lymphocytosis syndrome? It's a rare multisystemic syndrome which is described in HIV infection. Some patients who get infected with HIV, they basically immunologically develop an oligoclonal expansion of CD8 lymphocytes. So these CD8 lymphocytes, they multiply and they infiltrate various organs. The most common organs which are involved in this syndrome are usually the parotids, the lungs, and the lymph nodes. So common presentations which have been described in the literature include bilateral painless parotitis, generalized lymphadenopathy, and also interstitial pneumonia. However, there are certain uncommon manifestations of DILS which have been published. These CD8 lymphocytes can also infiltrate the peripheral nervous system, especially the peripheral nerves, giving rise to peripheral neuropathy. They can infiltrate liver, muscle, as well as the kidney. So manifestations might include hepatitis, myositis, and nephritis. In this case report in our hospital, we describe recurrent acute flaccid paralysis as an uncommon presentation of DILS. The case report is actually a 16-year-old male child who presented in our OPD with bilateral lower limb weakness since 3 days. It was an ascending type of paralysis. On examination, the child was, power was around 0, complete 0, non-ambulatory, bedridden. There was complete areflexia with no sensory involvement, no bowel bladder involvement. Hence, a provisional diagnosis was acute flaccid paralysis. And in this case, the most common cause would be Guillain-Barré syndrome. We confirmed the diagnosis by doing NCV, nerve conduction studies, which showed a generalized motor demyelinating type of polyradiculopathy, and did a CSF, which showed the classical albino cytological dissociation. Hence, Guillain-Barré syndrome was confirmed. We treated the child with IV immunoglobulins at 2 grams per kg, and we had a very good response. There was complete recovery of power within 10 days, and the child was discharged from the hospital. However, the same child, after 2 weeks, he again presented with acute flaccid paralysis involving both the lower limbs. Again, both the lower limbs, power was 0. There was complete areflexia, again, no sensory involvement, no bowel bladder involvement. This time, he was investigated for secondary causes of GBS. I'll be presenting some key results of the same. ESR was high. ANA, anti-nuclear antibody, creatinine phosphokinase, and urine porphyria were within normal limits. Hepatitis B surface antigen was negative. However, rapid antibody tests for HIV were reactive. The same time we screened the parents, both the mother and father, incidentally were negative. There is no history of any blood transfusion in the child. There is no history of any sexual exposure or sexual abuse. So we really don't know the origin of the HIV infection in this child. Once we got the results, we did a flow cytometry. CD4 counts were done, which were normal. However, with very high CD8 counts, close to 4,000 cells per microliter. Following which we did a real-time viral load, which was very high, 1.2 lakh copies per ml. USG neck was suggestive of cervical lymphadenopathy. X-ray chest and ultrasound abdomen pelvis was normal. So based on the result, you can see that this child has CD8 lymphocytosis with very high viral load. Based upon which we started treatment with ART, antiretroviral therapy. We used a combination of tenofovir, emtricitabine, and efavirenz. However, there was no improvement in power even after 2 weeks of ART. So, based on the literature, we decided to treat this CD8 lymphocytosis with prednisolone, with steroids, at a dose of 60 mg per day, which is the recommended dose, the maximum dose you can go for CD8 lymphocytosis. And the child responded very well. Within 4 days, the lower limb power returned to normal, and the follow-up NCV showed significant improvement in latencies. We followed the child at 6 weeks. So at 6 weeks follow-up on ART and steroids, 60 mg per day, the child had normal power. There was significant reduction in CD8 lymphocytosis. From 4,000, the CD8 levels had fallen down to close to around 1,000. And 3 log fall in viral loads. We did this again with real-time PCR using the same lab. Based upon the above results, we decided to taper the prednisolone and omit it over a period of 2 weeks. At 12 weeks follow-up on ART, the child continues to have normal power. So this case report basically provides us an insight into a very rare extragranular manifestations of diffuse infiltrative lymphocytic syndrome in pediatric age group. And it also tells us that DILS in pediatrics needs prompt recognition, and along with ART does require short-term steroid therapy for treatment. How does, is there any case report in terms of the literature which has been already published? There are certain studies by Gerard A. Price and Berger which have reported the involvement of peripheral nervous system involvement with diffuse infiltrative lymphocytic syndrome. And the type of peripheral nerve involvement is mixed. It could be either symmetrical involvement, asymmetrical involvement with or without sensory, even and most of them are demyelinating type, very similar to what we saw in our study. But all these studies have been published in adults. There have been no, to the best of our knowledge, no such studies or no such case reported in the pediatric population. And this is probably the first case report where we were able to see some amount of association between diffuse infiltrative lymphocytosis syndrome and recurrent AFB as one of its manifestations or one of its associations. So these are the references. And again, I thank everyone for listening to my talk and giving me this opportunity to present the data. Thank you so much.
Very, very well presented, and very good, astute clinical thinking, and how you went about to prove that it was an HIV-infected person. Just a few questions. Yes, you've done the nerve conduction velocity studies. You've done it twice, shown that there is regeneration of the myelin sheath as such. I'm only wondering, and because it's a very rare case, I don't want to do it for the purpose of case presentation, but have you done a nerve biopsy as such? The reason why I'm asking is, yes, you have shown cytoalbumic disproportionate rise in the CSF. A nerve biopsy is just to show if the CD8 cells are infiltrating the nerves. If you've got it, then you've got a clincher.
Yeah.
Okay,
Uh,
and
that's-
it will benefit the patient for future because there are so many other causes of recurrent polyneuropathy. I'm not saying it is refsums. I'm not saying it's chronic interstitial polyneuropathy, but just to make certain, have you done all the monoclonal, all the globulins levels, ultraphoretic strip, and other things?
No. First of all, that's a very good point. I mean, if you do a nerve biopsy and it shows CD8 lymphocytosis infiltration, that would clinch the diagnosis. In this case, we have not done, being an invasive study. Uh, so that, I mean, we can definitely, in order to, if we go ahead and publish, I think we will have to do a nerve biopsy.
Like you said, it's a rare case, but for the future of this patient, I was just
Yeah.
wondering, how long are you going to put them on steroids?
We
And
have already
completely
stopped.
removed?
Yeah, we have already stopped steroids 2 weeks back, and since after stopping of steroids, we followed the child and called the child on an OPD basis after 12 weeks, and still I mean, the patient continues to have normal power. So we plan to continue the same and just
also
follow the
this-
child and see what
any
happens.
cognitive dysfunction because the same myelin sheath exists in the
No,
CNS.
there is no higher function involvement.
Any questions from the audience? Yes.
So if you see the slide, we started the child on ART. After that, since the child did not respond, we put the child on short-term steroids. And we followed the child after 6 weeks. In terms of CD8 cells, right from initial CD8 counts were around 4,000. So the CD8 actually fell down to 1,000 at 6 weeks. And there were significant reductions in viral load. Why the viral loads actually declined significantly within 6 weeks' time, I really don't know. I don't have any explanation for that. However, at 12 weeks follow-up, only on ART, we have not repeated the CD4, CD8 count. Our plan is to repeat a CD4, CD8 count again after 6 months and see whether there is a further decline in CD8 or not. But at least at 6 weeks, the CD8 count fell from 4,000 to 1,000 with a 3-log fall in the viral load. Now, why a significant fall in viral loads within such a small amount of time is something which I cannot explain.
What was the repeat CD4 count? Because you have said there's a fall in CD8, but
The
even the initial CD4 count compared to the viral load was quite high. So
The
what was the
The
fall in the CD4 count?
CD4 count was normal, even in the first.
When you repeated it,
Yeah, it was within the normal range. It is the CD8 count which was initially high, which was
yeah,
around
but
4,000.
CD4 also was above 600, right?
Yeah, so
For
it
the
was
bi-
within the normal reference range for the patient. So there was no changes in CD4.
Thank you. Thank you. Yes, please.
Sometimes use the plasmapheresis instead of using the cortisols. Would this approach be possible in India? Just the plasmapheresis, because some of the symptoms are due to excess of immunoglobulins circulating.
So your question is whether you treat diffuse infiltrative lymphocytosis syndrome with plasmapheresis rather than with steroids. Is
No,
that
no. The Guillain-Barré syndrome. In
G-
some-
yeah, so you're right. For GBS, the treatment of choice is intravenous immunoglobulins or plasmapheresis, which we did initially. We did immunoglobulins when they presented with AFB. The second option obviously could have been a plasmapheresis. We usually don't do that because technically it's more challenging and we usually get a good response with immunoglobulins. But so that's definitely an option. But the second presentation, we clearly had the lab criteria that there is CD8 lymphocytosis, and this was fitting into DILS. So the treatment of choice for DILS is short-term steroids. I'm not sure whether DILS can be treated with plasmapheresis. There is some mention in the literature regarding as DILS as which patient of DILS who presented with parotitis, and he was treated with radiotherapy. However, they saw that using radiotherapy, there was a short-term improvement, but there were more chances. But the child, there was chances of recurrence. So I don't know whether I answered your question or not, but I really don't know whether immunoglobulins can be used for diffuse infiltrative lymphocytosis syndromes which presented at AFB. A plain Guillain-Barré syndrome with AFB, presenting as AFB, yes, we treat it either with immunoglobulins or plasmapheresis. Yeah.
Thank you.
Thank you.
Our second presentation today is carotid intima media thickness, high sensitivity C-reactive protein, and interleukin-6 in HIV infection and their correlation with immunosuppression. For presenting the same, can I invite Dr. Srinath R. from Puducherry?
Good morning to all. Upfront, I would like to thank the organizers for giving me this opportunity to present this research project. The title of the project is Carotid Intima Media Thickness, High Sensitivity C-Reactive Protein and Interleukin-6 in HIV Infection and their correlation with immunosuppression. A few points regarding background. HIV, as we know, is a chronic inflammatory state, and there is an increased risk of cardiovascular events. Cardiovascular events form a major part of morbidity and mortality regarding non-AIDS related events in the HIV population. And coming to CIMT, HSCRP and IL-6, all three are very good predictors of future cardiovascular events. And CIMT is an easy, non-invasive ultrasound-guided measurement of atherosclerotic burden. HSCRP and interleukin-6 are also good predictors, and they are also markers of inflammation. Basically, what happens in HIV is there is chronic monocyte macrophage activation, which increases the HSCRP and IL-6 levels, which also contributes to foam cell formation and atherosclerosis. So, HSCRP, IL-6 and CAMT are very good markers of atherosclerosis and chronic inflammation. And higher levels have been directly related to the occurrence of future cardiovascular disease. And what have the previous studies shown? Previous studies have shown that atherosclerosis and inflammation are found to be increased in HIV infection. But these studies have also included traditional risk factors like smoking, dyslipidemia, diabetes, hypertension. And in comparison with healthy people, are they really increased? Are the markers of inflammation and atherosclerosis increased in the HIV population? So there is a lack of matched controls, age, gender, and BMI, body mass index matched controls. These matched studies are lacking to find the real difference between the HIV population and the normal individuals with respect to atherosclerosis. And previous studies have not yet combined biochemical and imaging modalities in this assessment. And after adjustment for these traditional risk factors, is there a significant difference? And the influence of ART on inflammation and atherosclerosis is still unclear. Some studies have shown that with immune reconstitution, with increase in immunity, there is an increase in cardiovascular events, but it is still a topic of controversy. What are the objectives of our study? First, we wanted to assess the CIMT in HIV-infected individuals, assess the levels of HSCRP and interleukin-6 in HIV-infected individuals, and to compare them with age, sex, and body mass index matched controls. And the third objective is to correlate with the level of immunosuppression, which we did by measurement of CD4 lymphocyte cell count. And how is our study different? We have excluded all traditional risk factors, excluded all opportunistic infections. All our controls were matched for age, sex, and BMI. And we had combined both biochemical and radiological markers for atherosclerosis and inflammation. Coming to the methodology, it was an observational cross-sectional study. Point of contact was once, and the study did not have follow-up. Period was from 2014 to 2016. Sample size calculated was 178, and we divided it into equal number of cases and controls, 89 cases and 89 controls. We also wanted to see whether ART had any effect on these parameters, so we divided the cases into two subgroups, which is 44 patients ART naive and 45 on ART. And cases and controls were matched for age, sex, and BMI. Now the inclusion and exclusion criteria. For the ART naive group, patients should not have been exposed to ART. And the ART group, we wanted to have a reasonable time for ART to have an effect on inflammation and atherosclerosis. So we included patients who had taken ART for a minimum of 2 years. Exclusion criteria, all traditional risk factors for atherosclerosis were excluded. Diabetes, hypertension, dyslipidemia, smoking, alcoholism, ischemic heart disease, chronic kidney disease, chronic liver disease, all opportunistic illnesses concurrently which occurred during the time of enrollment, and any patient who required inpatient or intensive care. All these things were excluded in both the cases and the controls. And CAMT was measured according to the atherosclerosis risk in communities protocol, which was 6 sites, 3 sites on each side of the neck, which is distal common carotid, carotid bulb, and proximal internal carotid. We used a Siemens ultrasound machine for calculation of the CAMT. HSCRP and IL-6 were done using ELISA assays. This is just to show the measurement of carotid intima media thickness. This is the first image shows the right common carotid, and the second one is the right carotid bulb. Statistical analysis, comparison between cases and controls were mostly done using Mann-Whitney analysis. CAMT, the mean of the CAMT was done using independent samples t-test. Correlation, we used Spearman analysis. Coming to the results, baseline parameters, age of our patients, cases and controls were around 42 years. Body mass index was around 21 to 22. So these participants were not inherently predisposed to atherosclerosis. Gender, there was almost equal gender distribution, males and females, and there was no significant difference between the baseline parameters. Disease duration in the ART naive group was 6 months. These patients were not started on ART. And on ART, patients had taken ART for at least 2 years, and the median disease duration was 28 months. CD4 count, there was no significant difference in the CD4 count between ART naive and ART groups under cases. It was around 390 and 380. The ART regimens which were used in the 45 patients, by the year 2014, ZLN was recommended as the initial starting regimen. So most of our patients were started at around 2012, and around 29 of them were on ZLN. There was a little disproportionality in this. Other regimens were ZLE, TLN, and TLE. Coming to results of the outcome variables, HSCRP. This box plot shows the overall difference in the HSCRP between cases and controls. In the cases, HSCRP was around, median HSCRP was around 2.6, and in the controls it was around 1.8, and there was a significant difference, which was p-value was around 0.001. Coming to the subgroup analysis, in both the subgroups, ART naive and on ART, compared to their respective controls, HSCRP, which is a marker of inflammation, was increased. Coming to interleukin-6, again showing the comparison between overall cases and controls, IL-6 was around 19 in cases, and it was around 5 in controls. So there was a significant difference even in interleukin-6 between HIV infected and healthy controls. Again, in the subgroup analysis, IL-6 was also higher in both ART naive and ART patients. Carotid intima media thickness. This is a table showing the median CIMT values in millimeter at each of the 6 sites. Now we can see that at each of the 6 sites, carotid intima media thickness was higher in cases, with the p-value less than or equal to 0.001. Now when we combined all the 6 sites and we took a mean value, this is cases and controls. Again, we found a significantly higher value in cases. And when ART naive and on ART patients were compared with their controls, again it was significantly higher. But the level of significance was more with ART naive patients compared to ART. Correlation analysis, correlation of all these parameters with CD4 count, which is the level of immunosuppression. The first graph shows a correlation between carotid intima media thickness and CD4 count. This shows a significant negative correlation, which means the lower the CD4 count, the higher the carotid intima media thickness, which is implied as lower the CD4 count, higher the atherosclerosis. But what we did not find is a correlation between CD4 and HSCRP, correlation between CD4 and IL-6. This was not found. And a regression analysis, we found that the CD4 count amongst all other parameters like age, gender, disease duration, ART exposure, amongst all these parameters, we found that CD4 count was the major determinant of atherosclerosis. So summarizing the results, it was an observational cross-sectional study. Cases and controls, 89 participants each, and 2 groups under cases, ART naive and ART group. Traditional risk factors for atherosclerosis were excluded, and controls were matched for age, sex, and body mass index. There was no difference in baseline parameters. Outcome variables were all higher in cases compared to controls. And this difference was maintained in both ART-naive and ART-exposed groups under cases. And CAMT correlates positively with the degree of immunosuppression. There was no correlation between the other parameters. So what did we conclude? We concluded that HIV-infected individuals have higher levels of inflammation and atherosclerosis independent of traditional cardiovascular risk factors. The severity of immunosuppression was the major determinant of atherosclerosis. Now, we know that hsCRP, IL-6 and CAMT are all good predictors of future myocardial infarction, stroke and other cardiovascular events. So assessment of these parameters early in the HIV infection may be used to initiate preventive measures, probably statins or early ART. Our study goes hand in hand with studies like the START study, studies like the Temprano study, which all recommend early ART in order to decrease all-cause mortality due to both age-defining and non-age-defining illnesses. Thank you.
That is a very good study, very elegant design, case control, cross-sectional study, and you have used measures at the level of the common carotid, bulb, and the internal carotid.
Yes, sir.
But is there any standardization of that in the world, or as far as you are concerned in the general population as to what should be? Yes, you got it in the controls and shown the difference. That's good, one. And all the risk factors, known risk factors have been eliminated, hypertension and cholesterol levels, but you should also bring in that they had high HDL, that's also protective, and also levels of homocystinemia. If they've got high level of homocystinemia, then it is bad. So those are the other known risk factors for development of atherosclerosis. A wonderful study. On what basis did you calculate the sample size? You got 78 and 78. On what basis you calculated the sample?
There are very few studies which compare CAMT with respect to HIV-infected population and normal healthy controls. So based on the previous studies, they found a difference of 0.16 mm. So considering the difference, we calculated a sample size of 178.
Okay, of the intima medial thickness, and then you looked at it. Wonderful study. Any questions? But I would suggest that you follow it up, make it a longitudinal study.
Yes.
Okay, and see, that will be the proof of it.
We have around 750 patients in our ART clinic. Oh. So these patients which have been enrolled in our study, we have been following up for the past 6 months.
Okay, so that will be a subsequent presentation.
Yes, sir.
Very good, wonderful, wonderful. Any questions, sir?
Just one question here. Did you choose patients on ART? Because when you chose your sample size, you included all patients irrespective of their ART status, or then you chose 50-50 of each? Because that number I couldn't.
We just wanted equal number of patients on ART and those who have not exposed yet to ART.
And was there a significant difference in the levels between those on ART and not on ART? You have compared them with control?
Yes, ma'am. We found a difference.
It was CMIT, but for the others?
Only for hsCRP, we found that they were higher in ART-naive individuals.
Okay, but not.
They were lower in people who were exposed to ART. But we were not able to conclude that decrease in the hsCRP is due to exposure to ART because it was not a longitudinal design. Okay. But in a cross-sectional manner, we found that they were higher in ART-naive individuals. In CAMT, we did not find a difference.
Any questions from the audience? So you have to please come to the mic over here.
There's a mic in the center.
A very nice study, thank you. I was surprised that your patients who had been on ART for 2 years had the same median CD4 count as those who were naive and presumably awaiting therapy. Were you able to look back to see how many of the patients on ART had been severely immunocompromised, and were there in fact a group of sort of what we think of as immunologic failures amongst those ART patients?
Yeah. Individuals who are on ART, their median CD4 count was almost the same as ART naive. The question being asked is where these individuals who have a reasonably good CD4 count, were they severely immunocompromised at the start of ART. We have included patients who were throughout the exposure to ART did not have any opportunistic infections. They were exposed to ART for a median duration of 24 to 28 months. and all those who did not have opportunistic infections were excluded. So the chances of them having a low CD4 count to begin with was very less. So most of our patients were of good CD4 count even before they had started ART.
Can I ask? A very well presented data. Congratulations for that.
Thank you.
I know that your case and controls were quite very well matched. I was quite intrigued to know the age limit that you had. What was the upper age limit of your patients and controls? I know it was more than 18 you chose, the lower age limit. What was your higher?
The oldest participant we had was 62 years.
Oh, fantastic. Thank you.
For the next paper on coagulation abnormalities in HIV-infected patients and correlation with CD4 counts, I would like to invite Dr. S. Sarma from Lucknow.
First of all, good morning to the respected chairpersons and the delegates and all the...
Just take the mic a bit up.
Am I audible now? Greater is the victory of one who conquers himself than of him who conquers thousands of formidable foes. Today we are all here to fight against HIV. And myself, Dr. Sheetal, I'm coming from Department of Microbiology from King George Medical University. Today the study which I'm going to present is actually, I would like to is the coagulation abnormalities in the HIV-infected patients and their correlation with the CD4 count. Just to give you the brief introduction about it, actually the HIV infections are associated with variable number of hematological manifestations. Though we talk about the infections like the opportunistic infection like the toxoplasma, tuberculosis, histoplasma, candidiasis, coccidiosis, but there is a other set of infection like causes which also are as equally important for the mortality and morbidity in such patients. Studies have suggested that the venous thrombotic events are reported 6.5 to 10 times more often among the HIV-infected individuals than the general population, possibly due to increased inflammatory or hypercoagulable state and the presence of the concurrent comorbidities. Just a little bit about at the glance about the condition in India. 2.1 million people are living with HIV. 0.3% is the prevalence. 86,000 new infections, 68,000 AIDS-related deaths, 43% adults are on the antiretroviral therapy as the latest updates. So the aims and objectives of the present study was to screen for the coagulation abnormalities in the HIV-infected patients, detect the prothrombotic factors like protein C and S, and the levels of homocysteine as the possible precursors of the coagulation defects in the HIV patients, and detect the correlations of the CD4 count with these coagulation abnormalities. This was actually an observational pilot study which was a part of the MD thesis, so the number of the patients could not be much because of the financial constraints. This was carried out in the Tertiary Care Center in Northern India in collaboration with the Department of Pathology and Department of Medicine and my Department of Microbiology, and lasted for 1 year. The patient enrollment, we took HIV seropositive patients, and his number was 30, who were not taking vitamin K, antithrombotic or antiplatelet drugs, including aspirin or oral contraceptives, were included. Included subjects did not have any protein C or protein S known deficiencies. Healthy control, which were age and sex matched, and is equal to 30 were included in the study. So the HIV coming to the material and methods, the HIV seropositivity was confirmed by using 3-test algorithm according to the NACO guidelines. The CD4 count was determined by the flow cytometry using the Partick cytometer. Then the bleeding time, prothrombin time, APTT, and the CBC were evaluated for all the patients. Protein C and S activity were measured by a clot-based assay using reagents from the Tulip Diagnostics India. The serum homocysteine was measured on a semi-automated platform, and the results were compared with the HIV negative age-matched controls. Coming to the results, what we found was that the HIV seropositive patients had reduced protein C and S activity compared to the control, and it was statistically significant. The thrombophilic abnormalities in the form of hyperhomocysteinuria anemia was noted in the HIV-infected patients versus the controls, and these parameters had definitive correlation with the CD4 counts. The mean PT and APTT was significantly longer in cases as compared to the controls. Just this table to show the cases versus the controls, it is quite evident that the protein C and the S were lower in the cases as compared to the controls. There was a higher level of homocysteine in the cases. The PT and the APTT were also significantly higher in the cases, and the bleeding time was also increased. This is just how we correlated with the CD4 counts. It was differentiated into less than 200, 200 to 500, and more than 500. It was seen that the student t-test was done, and statistically significant values were found when the CD4 count was less than 200. It was found that the protein C deficiency, there was a statistical difference between the cases and the controls. Same was the case with the protein S. When their levels were less than 200, there was statistical difference. In case the CD4 count, when it was between 200 to 500 or more than 500, there was no statistical significance. And for the homocysteine also, when the CD4 count was less than 200, there was a statistical difference. Otherwise, there was no statistical difference in the cases and the controls. The other parameters which were looked for the PT and the APTT, it was also seen that when the CD4 count was less than 200 on each of these, there was the statistical significance among the cases and the controls, and same was the condition with the bleeding time also. But there was no significant, though the sample size was low, but there was no statistical difference when the CD4 count was more than 200. This is just to show you the coagulation parameters in the cases. The protein, it's quite evident when the CD4 count was less than 200, the graph it actually shows that there was a deficiency in protein C and protein S in the cases. The homocysteine was also higher in the patients with CD4 count less than 200, and PT and APTT was higher in such, and BT was also higher in the patients with CD4 count less than 200. So the results showed that the HIV positive patient showed the reduced levels also of the hemoglobin, platelet counts, and the platelet volumes as compared to the healthy controls, but that data could not be taken statistically significant. Out of the 30 cases, only 2 cases developed thromboembolism in the form of the MI and the stroke, and both the patient died. Coming to the discussion, the thrombophilic activity in the form of the homocystinuria anemia is more frequent in HIV-infected patients as compared to the healthy controls. APTT and the PT are correlated with the CD4 count, and endothelial activation is suggested as the possible mechanism for the coagulation defect. So to conclude the study, the findings of the present pilot study suggest an association between the HIV disease and the coagulation abnormalities, and with the increasing survival of the people living with the HIV due to better and cheaper access to the antiretroviral therapy, larger studies are warranted to define the HIV positive population at risk with the thrombosis. With this, I'll come to the end of my presentation. Thank you to all of you for being a patient audience.
Thank you. Thank you for your presentation and your observations as such. In the introduction part, you would probably like to say that none of these patients had thromboembolic phenomenon as such, because you have not measured the protein C and protein S. Yes, I do agree with you that there are coagulation abnormalities, and your study sample size is 30, but no problem. It's a good beginning. It's a good beginning, and you've got that thought process, because it is essential for us to know. But there are so many other factors, the coagulation factors that you have checked out are on the crude side, but nevertheless, that is what is available as such, because you need to do more dynamic studies with the platelets as well as thrombin time, as well as even levels of HDL and other things, but very good and small beginning. Only concern that I had on this is I didn't see the number of females are not that many in this study, the gender.
So the gender,
Yeah, all males.
so gender was it 15-15 each we had taken?
50-50.
It was just a pilot studies.
One thing you had said when you're talking of the differences between the cases and control, there was a difference, but was the difference statistically significant? For protein C, you said it was the difference, but for other parameters, was the difference?
Yes, ma'am, it was
You did not
statistic.
mention the p-value, so just...
Ma'am, I had mentioned the p-values.
I must have missed that. And it was an observational study.
Yes, ma'am.
And then you said 2 patients reported of MI and stroke later on. So you're following up these patients, or?
Yes, ma'am, we
It's
had
cross-section
followed up.
study it was, right?
It was actually, ma'am, the kit of the homocysteine, like cysteine was 70,000, so it was like a limiting factor for us to increase the number. But we followed those patients, and it was like, because they were enrolled in our department, and we came to know, and because the sample size was less, so we were able to follow up the patients.
Okay, thank you.
Thank you. So great presentation.
Thank
The
you,
most
sir.
cool thing is how you switch between the slides. I love that. That's great. So my question comes from a patient that I saw literally a month ago, and he came in with the second episode of a DVT. The first one was in the calf. The second one, a month ago, was up to the vena cava, sort of massive DVT with a PE. And we did a whole workup after the first one, so not when he was in this hypercoagulable state, and we couldn't find anything as far as the abnormality or the coagulation abnormality. So what I want to ask you is, and maybe you mentioned it, but I missed it. So I understand there were differences between HIV positive and negative, but were the differences in the HIV positive below or above the reference values explaining hypercoagulability, or they were just higher?
It was below. So the protein C and S were significantly below, and the homocysteine was quite elevated.
Thank you.
Thank you for good presentations.
Thank you.
Problem is the sample size is very small, so making conclusions is very difficult from the study. Second thing that I want to know, are they on the ART or not on ART? And does the ART modify the factors? That sort of study should have been, at least some patients are ART, some not on
So
ART.
the subsequent study which we are planning to do is actually taking a bigger sample size and defining the criteria whether the patient is on ART or not ART. But in this particular study, we did not focus on that factor. It was just a pilot study to see whether there is certain abnormalities we can found. So because we found it, now we are planning to do this particular study. And in future, ASICON, I look forward to present the similar study.
Thank you.
Thank you, Dr. Verma.
Thank
Good
you, ma'am.
presentation.
Thank you, sir.
For our next presentation, CD4 correlation with micronutrient deficiency among HIV patients, a cross-section study. I would like to invite upon Dr. Sangeeta Kandaswamy from Thene.
A very pleasant good morning to all. First, I thank the organizing committee giving me this opportunity to present my research topic. And my topic is CD4 correlation with the micronutrient deficiency among the HIV patients. It is a cross-sectional study. We all know this HIV infection is a major public health problem in the worldwide. And this virus mainly affects this immune function, so particularly CD4 cells. So this immune function is highly depends upon the nutritional state of the individual. And this nutritional assessment has a high predictive value for survival and this functional status of this individual and during this HIV course of infection. And so the assessment of this nutritional status is very important for an HIV patients. This is a small epidemic of a HIV. In 2015, deaths due to this AIDS around 1.1 millions. And in our country stated the third position. So they reduce the mortality rate which is in our hand. So the assessment of the nutritional status is very important for this HIV infection. And this is the few micronutrients important in our body, which is to maintain this protein synthesis, cellular energy production, and cell growth, bone formation, nerve conduction, and hormone secretions, and the maintenance of this vitamin functions also. And this micronutrients will reduce the virulence and progression of the HIV infection, and which is improve this immune system via the zinc and magnesium, and it is this micronutrients also act as an antioxidant. And this major clinical lacunae is the manifestations of micronutrients we are unable to detect. So the importance of this micronutrient assessments is very important for an HIV patients. And why these patients are more prone for an micronutrient deficiency? Because this chronic gastroenteritis, reduced appetite, and poor socio-economic status and psychosocial problems. And we all know this is a chronic infection. So during the infection, it will produce a lot of cytokines and oxidative stress and free radical damage. So which will causes this multi-organ system failure. So this release of infection and this free radical damage, which can be neutralized by micronutrients. And this is the course of the infections. Here, this after the 1 year, the CD4 count is going to be decreased because of the infection. So after that, the cross infection, and which leads to a micronutrient deficiency, and which leads to a CD4 count decrease. So this is a vicious cycle. So we have to break the vicious cycle between this micronutrient deficiency and the CD4 counts. So this is our main job, will reduce this progression of the HIV course. And coming to the aim of our study is to correlate the CD4 counts with the micronutrients and this anthropometric levels. And this is our inclusion and exclusion criteria. It's a cross-section study we conducted in our government Theni Medical College in the Department of Biochemistry and this Department of Internal Medicine during the course of 2 months. And after this institutional ethical committee approval and informed consent from the patients, we collected the blood sample from the patient, and according to the selection criteria, we got 144 patients. And this is the age distribution of this, our selection criteria. Here, the highlight of this age distribution is a maximum between 30 to 51 years. So in this age group, the individual support to the family is very important. So the progression of the disease is supposed to be decrease for the social status. And this is an age distributions. So we got 59% of the female and this 41% of the females. And in this, our selection criteria, this 81% of the people comes on stage 1. And this is the parameter we estimated with the methods and this normal value. We estimate this analyte in this fully auto analyzer. And this is the mean standard deviation of this patients with an BMI ratio of this mean is 21. And this is the biochemical parameters of mean and standard deviations. And this is a correlation between CD4 and this other variables. Here, a serum magnesium and zinc level is highly significant with the CD4 counts. And BMI is also correlated with this p-values. And this is the scatter diagram shows CD4 count cells, which is correlated with the serum magnesium levels. And this is again this correlation between the CD4 and this serum zinc levels, which has a positive correlations. And this is an CD4 with an BMI. And this is a statistical method we use. For correlation, we use the Pearson's correlation coefficient test. And in our the study conclusion is, so this microdeficiencies may be common in people living with HIVs. So, and this early we find out this magnesium and zinc deficiency is happened in the study, and which is also correlated with CD4 count cells. And so the micronutrient supplementation is very important, which will break this vicious cycle and helps to prevent this opportunistic infection, and which is also enhance the adherence to the ART drugs and improve the quality of life to those patients. And This is a small recommendations with an better nutrition diet chart, and this assessment this nutrition status 1 to 2 times per year for an asymptomatic patients and 4 to 6 times per AIDS related patients. And nutritional counseling based on this local availability foodstuffs, and with the addition of this endocrine and physical activities. These are the references. Thank you.
Thank you. Thank you, Dr. Sangeeta. What you have shown is an observational study.
Yes.
Good, and you may not be able to derive so many recommendations on that, but not to worry. But it's a small beginning, and there are so many other trace metals that one needs to look at, cobalt, molybdenum, and other things, but you have made a good beginning as such. Very good observational study. Are there any questions from the audience? If not, I would like to thank all the presenters for this, for their presentation. And I made an observation that the whoever had seen this selection had selected Sunil, Dr. Srinath, Dr. Sheetal, Dr. Sangeeta. All 4 of them names beginning with the letter S. So that's it's purely a coincidence or an observation. Thank you very much, Sangeeta. Thank you so much for your presentation.
Thank you to the chairpersons and all the speakers. We'd like to thank the chairpersons with a token of appreciation. Dr. Dilip Mathai, can you please present it to Dr. Naina Engole? Thank you. I'd now like to call upon medical